kindly, Dr. ELAINE Drysdale has agreed to give the first 20 minutes of her talk, and it's going to be on practical tools for spiritual assessment. Dr. ELAINE Drysdale is a clinical professor of psychiatry in the Faculty of Medicine at the University of British Columbia, and her full talk will be done at the time that is on the schedule, and then I'll further talk to you about her. So at this time, let's welcome Dr. ELAINE Drysdale.
Thank you so much for your
Okay.
flexibility.
Okay, just before you go,
Yes.
I want to make sure I know what I'm doing here.
Let's do that. So this is your clicker if you need one.
Okay. Yeah.
And I don't know if you want a timer. Do you want a timer?
No, I'll
Since
just
you're
go-
ad-libbing and you're being so kind and flexible, I don't know if you
I
need
just
a
want.
timer.
Do you want to just stay up here in case I?
Yes, I can do that.
Okay. So I am thrilled to be participating here at the conference, and very honored to have been asked. And I would like to say a huge thank you to Dr. Doi and to Andrea, who's done so much great work in organizing the logistics as well. And it's been a superb conference from my point of view, so thank you. So my talk is about the integration of psychiatry, spirituality, and the use of NDEs, near-death experiences, in clinical practice. So this afternoon, I will be talking about near-death experiences and how I use them. But what was apparent yesterday was that people were asking for practical tools in how do we apply spiritual investigation, spiritual kinds of therapy. So I'm going to present a few slides on the very kind of nuts and bolts of how we can do this in practice. I must say, it's not quite as exciting as that wonderful talk that we just heard now and all that fabulous information investigating mediums. It's very exciting. If you don't see patients directly, I trust you can still apply some of my thoughts and stories to people generally, or when you wish to introduce or deepen spiritual discussion. A little later, will mostly be this afternoon, so that when you see a patient or a friend who is distressed, the most helpful story will pop into your awareness to provide the most hope and healing in the circumstances. Stories of the experiences of others have the power to uplift us, to provide hope, and to provide a broader perspective, and possibly shift the paradigm as to how we understand reality. However, I, like many of you, was trained in a mainstream institution and was taught to take a methodical history geared to left brain linear thinking and organization. Most of us are expected to function in the roles for which we have qualified. We need to be open to intuitions, but at the same time provide excellent conventional care. So, yet in dealing with intuition, dreams, and visions, we must also be open to the spiritual input that patients wish to discuss. Spiritual perceptions and interpretations are not easily shared by patients when we are in a standard medical mindset. So how do we marry our conventional receptivity? So for the next few minutes, I'm going to attempt to give just a few approaches. So what is my credibility to speak about this? Well, I attained a medical degree and followed by some internal medicine training and board certification. But basically, I've been working in the trenches of life and clinical care for seeing emotionally distressed people on psych inpatient wards, on psych outpatient clinics, supervising psychotic patients in a daycare program, and working on medical wards with many patients who have delirium and life-threatening illnesses. I started a psychiatry department at a cancer agency, so I've seen many cancer patients over the past 20 years, some who have passed on and some who've been living with it as a chronic illness. I've also been the consultant to the leukemia bone marrow transplant program for 25 years, and which can be very acute medicine. It's like an ICU unit. So a lot of these patients are facing imminent possibility of dying, and they either make it through or they suddenly die. So I'm used to seeing people who are quite terrified suddenly without much preparation for it, suddenly diagnosed with leukemia at times. As part of my journey, I had the opportunity to co-lead a group for women who were dying of cancer, with metastatic cancer, to see if they would live longer if they participated in a weekly support group. We all experienced much laughter, tears, and heartfelt moments, and I was honored to give eulogies for most of the women. So my involvement there with those vibrant women was a tremendous blessing to me. And I've consulted in hospices about what I've done, but to tell you that I've been in patients in inpatient units, I've seen delirious patients, I've seen patients afraid of dying, and I've also worked in emergency for the past 30 years, seeing psychotic patients, suicidal, homicidal, distressed people. So I've seen humanity at its most distressed and frightened for years. And so I would like to talk to you about where my clicker is. Yet in all of these situations, there's been very minimal addressing of spiritual issues by the institutions that I have been in. So how do I incorporate it? Well, the first thing is to overtly create awareness of spirituality. And in the 1980s, oops. That's this afternoon, so there we go. In the 1980s, we talked about the biopsychosocial approach, and I think just using the term, shifting it to biopsychosocial spiritual model makes a difference. And when we're doing formulations after diagnosis, we can talk about predisposing factors, biopsychosocial spiritual, precipitating factors, biopsychosocial spiritual, perpetuating, again, using that term over it, with the residents, it gets into their thinking of just automatically thinking spiritual as well. And this is a way of formulating it with biopsychosocial, predisposing, precipitating, perpetuating, protective factors. But I usually do it sequentially. When we're doing an assessment, we've got to be alert in thought content, because there may be religious or spiritual themes, and also depressive thought content overlaps highly with spirituality. When people are depressed, they become more guilty in their thinking. It may be generalized, pervasive, or it may be more guilt about specific areas. They feel more sensitive to criticism. It's a mild paranoia, which can be very mild, or it can go to extensive and psychotic, and they can have low self-esteem. So that all overlaps with spirituality, and the self-esteem overlaps when people feel that they're not adequate spiritually. When people are manic, then they can have increased religious content. But beyond that, when we're looking at the mood, when people are depressed, they lose their faith. And when they're manic, they can have increased intensity and zeal. So I just want to make a quick comment about that there may be some connections between the mood areas of the brain and the spiritual areas of the brain, such as the right temporal lobe, or it could be the left prefrontal cortex as well. And so that when people are depressed, the functioning is diminished in the neurotransmitters in the mood part of the brain, but somehow it's impacting in the spiritual centers. So I think that's why people lose their faith, and we often think, well, that they've lost their faith, and they don't go to church, therefore they're depressed. But it may be that they're depressed, and that causes the loss of faith from a biological basis. And the same thing with mania, that when people are manic, they become hyper-religious on a biological basis. That's very important to consider of, say, church attendance when people may be avoiding church because they are depressed, and that's impacting on the spirituality. Oops. So in asking spiritual questions, a lot of you are familiar with Dr. Pachalski's model. I have been using an alternate model, the HOPE model, which was designed by Canadians. And it's basically looking at the letters of the word hope. H, sources of hope. What gives you hope? O stands for organized religion. Were you raised in any religion? Do you still attend that church, that religion? If not, why not? What are your personal beliefs and practices of spirituality? Are there any beliefs that you have that are different from your official church dogma, or such as reincarnation, for example? And are there any practices that would impact on your medical care? And E stands for effects on medical care and end-of-life issues. Are there effects? Are there issues from your faith that would impact on how we provide medical care for you? Now, there are major spiritual themes at the end of life. Fear of abandonment by God or people, isolation, fear of the unknown, and anger and fears about imminent death. So those are some of the questions that I use, HOPE. They're very quick and very easy to do, but I often see patients who are nauseated, in great pain, or they're dying, so I cut to the chase. And they say they have leukemia, they're worried that they could die within a few days. And so I say, do you believe in a spiritual realm? Do you believe in a God or higher power or deity? What about an afterlife? And they might say, no, I don't. And then we go from there. But it's helpful to know. It's very simple to provide support if the patient is in anxiety about dying. It sounds obvious, but these questions are often missed or considered too private. And health professionals often don't ask because they don't know how to respond. So how are we doing for time? Okay. So those are just very simple questions, but you don't need to be a chaplain or have a Master's of Divinity to ask them. Whoops. Sorry, I didn't have a chance to come up here to practice ahead of time, so I'm dealing with some logistic issues of the screen in one place and text elsewhere. So I'm sorry it's not quite as smooth, thank you, as I would have hoped to be, and it sounds a little anxious and rushed, but that's partly why. So anyway, I hope that it will be much smoother this afternoon and the presentation about near-death experiences. So in looking at some of the spiritual predisposing factors, what are some of the risk factors? Well, people can be vaccinated against religion if they've had a little bit of meaningless ritual, or too much of it, I should say. Or sometimes their experience has been too little or wishy-washy. So it's quite funny, I'll say, do you have any exposure? Were you raised in any religion? No. And I say, well, did you go to Sunday school? Oh, yeah, I did. And it's either that they were, as I say, vaccinated against it, or it never really took. But some families are quite hostile to spirituality and religion, so that doesn't help patients cope later if they've been raised in that kind of environment. There may be lack of psychological or spiritual mindedness in the family. Sometimes people to Father, so when they talk about God the Father, they don't perceive God to be very loving. Lack of family teaching of forgiveness. Some families raise their children with a get-even attitude, and so that's not going to help them when they have to cope with difficulties later. What are some of the triggering factors? Well, some of these themes, as I said, can overlap with mood disorders. There can be loss of meaning in life, feeling abandoned by God, anger at God, feeling punished by God. So sometimes I will say, do you have some kind of question or conclusion about why you have this illness, or do you have thoughts about that? And they might say, yes, I'm being punished because I had an affair. Or they might say, no, I have no idea. In fact, I'm very angry at God. I've been a very good person, so why am I suffering? So that's more common. And there may be theological differences with others. Family division over the role of prayer. Now this might sound, so I'm going to give you a very interesting example. I had a patient who was very ill, and he said, my friends want to pray for me. What do you think? So I thought, well, that's a no-brainer, and I jumped in where fools rush in where angels fear to tread. So I said, oh, I think that's a great idea. Dr. Dossi talks about the role of prayer. Beep, wrong answer. Because I said, why are you asking? Which I should have asked him in the first place. And he said, well, my friends want to pray for me, but what if it doesn't work? My children will lose their faith. And what if it does work? My wife will then think her support is not enough. Which blew me away. It surprised me. And it surprised the nurses, the staff, when they learned that. But that was the tip of the iceberg. The real problem was, of course, the wife's issues manifested as a spiritual issue. It came to a head. So asking about that and not just assuming that you know the answer is important. In the family. Some of the family was at one door and the other family was at the other door. And there can be differences from the pastor. Sometimes patients are told that they're going to go, they feel they'll go to hell if their beliefs aren't strong enough or if they question. So. Now, all these things are things that have come up in my own clinical practice. I didn't get them from a textbook. So they're ones I've had to deal with. Sometimes sudden confrontation with mortality. One patient in his 40s said, well, I've never thought about dying. Have you? Which shocked me because I've been thinking about it since age 12 at least. There can be anxiety about punishment or in hell, fear of judgment, fear of leaving loved ones in one's life. Fear of separation due to different beliefs. One patient of mine was a born-again Christian, and who was dying, and she said, "I'm afraid that I won't see my husband after I die." And her pastor, and he said, "You're right. He's not saved." So then she went to her family doctor, and he said, "Well, I don't know how to deal with this kind of issue." So they sent her to psychiatry, and thank heavens I was interested in spiritual issues. And so we sorted that out, actually, to try and get her to think outside the box. I talked to her about near-death experiences to broaden her perspective of heaven. We talked that maybe if she loved her husband, maybe God loved her husband, and that she couldn't just think of heaven from our perspective like puny little caterpillars, when perhaps we should be seeing things more like butterflies who have a broader perspective. And so in discussing about near-death experiences, that really helped her, and she died sometime later with the situation much more resolved in her heart. And that's what I'm going to be talking a bit about, clinical applications of near-death experience. And I'm almost finished this part, but I want to talk a little bit about perpetuating factors, because sometimes people are so anxious about death that they avoid the topic altogether. They don't go to funerals or watch movies where anybody could be dying. I had one patient who had leukemia and was very ill, and she had a pre-existing phobia to the topic of death. She'd never been able to watch a TV show, even cartoons where somebody would die. She'd avoided funeral discussion. So here she was with me, talking to me, that she was dying of leukemia and couldn't deal with it. I tried to get her to face the issue through different ways, talking about stories, films, books, but actually this was her defense mechanism. She was admitted to deny that death. She was admitted to the palliative care ward, And the day before she died, she said to me, "See that nurse over there? He's so cute. When I get out of here, I'm going to date him." So, you know, we have to respect that patients have different defense mechanisms. And for her, she was in denial about her terminal condition, but it would have been cruel to have forced her to acknowledge it and to say, "Look, don't you realize that you're dying?" So I call denial the scab of the psyche, because it's a protective thing for people when they're vulnerable. And when there is healing underneath, a scab falls off. And similarly, when there's healing psychologically or spiritually, that denial can dissipate as well. But for that patient, her death phobia was lifelong, and so she died happily thinking that she would soon be dating the nurse. So the next part is, what about the more mystical spiritual experiences, and how do we, what's the best way to open the dialogue about that? And that is going to be my topic for this afternoon, and I hope it goes more smoothly than the start of this one. So.